All right, class, we're going to move into our next unit, which is clinical therapy. How do we go about treating a patient with some abnormality, a diagnosable disorder? And so for today, we're going to focus on how a clinical psychologist would go about treating bulimia. What I want you to do is first fill in the left half of the bulimia worksheet, where it's asking you to list the etiology and the symptoms of bulimia nervosa. So review your information that we have from Unit 6, where you would look at the biological, the psycho, the social causes of the disorder. For the symptoms, give me some of the affective, behavioral, cognitive, and somatic symptoms. So once you've filled in that part of the worksheet, then you can start this lesson, and we'll go through and talk about the different approaches. It'll have you stop at different points. You can fill in the other half of the chart. So put this on pause for a moment while you do the first part of the assignment and fill in the left side of that bulimia chart. All right, now that you're ready to move on, let's take a look at the biomedical approaches. We remember from AP Psychology that biomedical therapies try to address psychological disorders the same way a physical doctor would address any other type of illness. So if I have diabetes, well, they'll give me insulin supplements to help with my body's not producing. So for a psychological disorder, well, maybe I'll give you medication that'll help balance out some neurochemical issues within your brain. We do know that there's a high rate of comorbidity with bulimia and depression, so patients sometimes have both. So the most common biomedical approach for treating bulimia would be an antidepressants. It's rarely used with bulimia in general. It's not the most common approach, but it can be usable, especially if the depression is very influential behind the binging behavior that they have. Right, so we could use SSRIs, selective serotonin reuptake inhibitors, and they tend to be very successful. When they're applied to patients, they tend to lower cases of binge eating, and so the overconsumption of all those calories. It tends to reduce cases of vomiting as well, the purging side. If you're put on a low-dose SSRI, it's not as effective with the vomiting issues. The higher doses tend to be more effective, but it carries a lot of those negative side effects. There's increased risks of suicide and self-harm with SSRIs. So what you could also try is maybe a tricyclic antidepressant. I know I didn't cover this in my class, so I don't know if it was addressed in Miss Young's AP class, but tricyclics are antidepressants that affect 3 different neurotransmitters versus SSRIs just focusing on serotonin. Right, what these drugs try to do is they raise your levels of serotonin and norepinephrine while also inhibiting acetylcholine. Acetylcholine is an excitatory neurotransmitter. It helps with memory formation, muscle coordination, but it also is linked with higher rates of anxiety. And so what we find is by boosting the feel-good neurotransmitters, serotonin and norepinephrine, but lowering the effects of acetylcholine, it helps minimize those anxious, depressive feelings as well. There are some problems with tricyclics, and they aren't as effective as SSRIs, but with tricyclics, it could influence higher rates of constipation, increased heart rate, blurred vision. It increases seizures, especially if the patient already has epilepsy, so definitely don't take that. And you can't go off the drug without a slow withdrawal process. Individuals who go off the drug cold turkey have very, very negative withdrawal symptoms, and so they tend to use like a step-down process where they'll lower the dosage, lower how often, frequently patient will take it, and so eventually the drug will slowly leave the body, and those negative withdrawal symptoms are lower. All right, so if those are the biomedical approaches, again, not commonly used with bulimia, but if you were going to give a biomedical approach to treat this disorder, explain how it would either address the causes and fix the issue, or how it could address the symptoms and some of the problems with that. So go through and in both sections, both sides of the right chart, address how a biomedical treatment option could affect either the etiology or the symptoms of bulimia. All right. Another option, and this is much more common with bulimic patients, is we could use an individual approach. One-on-one face therapy to talk with our patient, what they're going through, their emotional state of mind, and try and come up with a individualized plan to help them. All right, so cognitive behavioral therapy, CBT, that's the most common individual treatment option that we would use with bulimia. We try to address most of their cognitive appraisals. We know that body dysmorphia is a cognitive cause for bulimia where they can't accurately see their body. Those impulsive measures, and so the disinhibition where if I have one, I have to have all. And so those cognitive appraisals are slightly off. And what a cognitive behavioral therapist would try and do is first address their individual perceptions of the world, their individual cognitive approaches, and then come up with a behavioral replacement. So they'll be less likely to binge on food or less likely to go through purging procedures afterwards. And so those behavioral replacements will be linked to whatever the individual cognitive interpretations are. A lot of cognitive behavioral therapy will have the bulimic patient keep a food journal, which sounds like it won't make sense, but it is practical in use. If someone has a problem with food and food consumption and is very obsessed with their weight, why do we want them to track all of the food that they consumed? Well, by keeping this food journal, they can see it written out when they're eating, how much they're eating, and what they're eating. And by talking about this food journal with their therapist, well, maybe they can come up to develop a healthier relationship with food, have a better acceptance of their weight by addressing that these fall within normal realms. These are typical eating patterns that others would demonstrate. And so by having a physical object that looks at their normalcy, it helps the patient develop more of a healthy relationship with food. All right, and they want them to be honest with this, right? If you've actually binged, that's fine. Don't hide that from the therapist, but we can talk about what triggered it. All right, what was your emotional feelings around that meal, both before, during, and after? And so they can address those emotional feelings to identify what mental states might be triggers for these binging behaviors, so we can also work through those type of things. And so a food journal is a really effective tool that a patient can take and use with them at home and then have with them in therapy to kind of work with it. And so these journals help the therapist understand a lot more about that mental state or cognitive appraisals and try and address those like faulty thinking patterns where maybe they have a very low self-opinion of themselves, low self-esteem, those never-ending issues that we talked about with Ellis's theory. So those could be playing a role in why they feel the need to binge or purge. Right? If we're going to do a comparison between the biomedical approaches and the individual approaches, we know that any types of studies we do is going to be difficult with bulimia. In order to treat a disorder, a person has to be diagnosed, willing to seek help, and across all the disorders, we're going to look at depression, post-traumatic stress, and bulimia. Bulimics are the ones that are least likely to be diagnosed, either because they treat it on their own, they don't go see a doctor. When they go see a doctor, maybe it's diagnosed as something different, maybe, and since there isn't a large weight fluctuation, we know it can go undiagnosed for long periods of time. So usually the ones that are in our treatment plans, these are the most severe cases. And so it might not effectively generalize to the rest of the populace, but the controlled studies that we've done is we find that cognitive behavioral therapy tends to be more effective than medication. They got a group of subjects together. They put a third of them on just biomedical options for therapy, a third of them just using cognitive behavioral for therapy, and a third of them were on treatment with both biomedical and cognitive behavior together. They didn't have a control group because that would be unethical. Why? Put that in a private comment. If it's correct, I'll give you an extra credit point. But yeah, so they had those three groups, and then they just compared their rates of binging and purging, and did they drop? And then they looked at how effective the treatment was for how long the patient was in therapy. And so what they found is that our combination group did the best. Their symptoms disappeared at a faster rate, and they recovered, they got out of the inpatient therapy unit at a faster rate as well. Most of the people in the cognitive behavioral therapy, they stopped the binging and the purging behaviors completely, where it was a slower return. Some of those on the biomedical stopped the bad behaviors, where almost at a lower rate than those in the cognitive behavior. And if we looked at the three groups, our biomedical had the most often patients that did not improve at all. So they didn't see any minimizing of the symptoms, and they were in the treatment program for a longer period of time. All right, so if those are our individual options, look at cognitive behavioral therapy and how could we use this to either address the causes or the symptoms of bulimia. All right, so just like you did with the biomedical, repeat this with the individual by tying it to a specific cause, specific symptom that we could be able to use this treatment plan for. All right, and then the last thing we could do is we could use group approaches. Right, group therapy is very effective with bulimia. So for example, one of them is a family systems model. It looks at the psychoanalytic approach and tries to apply it to our bulimics. We know that there is a strong correlation between mothers who've had eating disordered behaviors and their daughters being diagnosed with bulimia. And so maybe this issue stems from the family, and so we could use group therapy to treat this. All right, what they do is they say that individual issues, mental instabilities, actually stem from a big problem within the family. The family itself is dysfunctional. And so what we want to do is address those unhealthy family relationships, the practices within that family unit, and restructure them so that it becomes a little bit healthier. So looking at what should a parent give to a child, what should a child give to a parent, those healthy versus unhealthy pressures that both put on the other. All right, so maybe we can restructure that family to minimize the tensions and the stress at home, and those tensions minimizing will hopefully help our patient recover because they have a safer home base to go back to. If we compare family therapy to cognitive behavior, both of them are equally effective. Cognitive behavior was faster on reducing the binging behaviors, but if we looked at duration and therapy treatment programs, it's a lot. Both of them recovered at the same fast rate. Some people criticize this because it focuses too much on the past rather than current issues. Are we really blaming all of our parents for my individual choice for my behaviors? And how much responsibility, how much blame goes to the parents for those individual actions? All right, we also know that most people look to their peers for what they decide to do in adolescence. Since adolescence is when bulimic behaviors tend to start manifesting, maybe it's actually maybe it's actually something that's happening at school. Maybe it's those media influences, because we know the media puts a lot of body image pressure on people. And so is it really the parents' fault when it might be just an individual problem? All right. We also could do group therapy where we get all patients who suffer from bulimia together to work through those issues. We like group therapy because it gives you a safe space to share with people who understand what you're going through because they're going through it also. They can offer tricks, things that they've done to help them recover moments of stress and try to prevent these binging, purging behaviors. All right, if we want group therapy to be effective, we need to make sure that there's good group cohesion. Right, everyone gets along, everyone's going into it the right frame of mind. There needs to be accountability and attendance rates, and so usually this is used within institutionalized settings where you're expected to show up and be in a right frame of mind. Right, so that forcing element might not be the best. Some programs use a mentor-mentee type of mentality where an individual in the group actually holds the other person accountable for showing up. So almost like a gym buddy type thing. Like, we're going to go together, we'll exercise together, we'll leave together. Well, we're going to go to therapy together, and we're going to work on this together. It's really effective if it's also used with other therapy techniques, so either a biomedical or an individual approach. So that way, if maybe the group cohesion or the accountability isn't there, you still have the individual plan to fall back on. An issue with group therapy is maybe it'll actually reinforce these abnormal behaviors. My tricks that I offer as a coping mechanism might also be a trick that helps you hide your binging, purging behaviors or other ways that might make it easier, faster for you, which is still encouraging the abnormal behavior to continue. Since bulimia is also linked with weight obsession, we do find sometimes in group therapies with bulimic patients that there's a weight competition, so who can manage their weight, lose the weight the fastest, and so it adds a new, almost anorexic element into the group dynamic, which is problematic. And so you want to make sure that you're aware of what the group is focused on. And as long as they can remain optimistic, as long as they're not ostracizing certain people, if you're the one person who's not fitting in with the group, that group therapy is not going to be helpful for you. And so, again, you want that good group cohesion. But we can get similar people together and they feel safer and more comfortable talking with those coming from a similar background, from similar pressures, and that might be a more effective group approach than maybe addressing family units, knowing that there are some potential drawbacks. All right, so go through your chart and fill in this part, addressing group approaches and how could it be linked to either a cause or a symptom of the disorder. And then once you finish that, make sure you do your closing reflection. Oh, I don't know why it's that small. All right, looking at all of the therapy options, we talked about the goods and the bads. Imagine if you were a clinical psychologist. All right, if you had to pick a therapy option to use with your client who suffers from bulimia, which one would you use? All right, in your closing reflection, make sure you have a good, strong thesis. All right, give me some evidence to support your answer. It doesn't need to be very long. Again, just about a paragraph in length. So do that, and once you've finished your closing reflection, submit your worksheet, and we're done for the day.